welcome and thank you for joining me today. I'm going to give some broad thoughts on spending and value in the healthcare sector, and then talk about some potential ways at a system level that value can be created. So first, let me see if I can advance my slides. I'm having a hard time advancing my slides. Oh, there we go. Yes, it was a little slow, I think. So I think across the globe, healthcare spending has risen faster than income, essentially in almost all countries, at least all the countries that I'm aware of. And this spending growth creates financial pressure for payers. In systems where there's fundamentally government payers, it creates fiscal pressure for the government. And in systems where there's private payers, it creates pressure on them. And of course, in places like the United States, we have both, it creates pressure financially for everybody. This crowds out a whole bunch of other economic activities that may or may not be bad, of course, depending on the value of the healthcare relative to the value of the other economic activities. And so the real challenge is how to make sure that we get value for the healthcare dollar that is being spent. I'd like to start with some broad conceptual issues. First, I want to make a distinction between the level of spending and the rate of growth in spending. So the level of spending is sort of the intercept of the line. How much are we spending at a point in time? The rate of growth in spending is the slope of that line. How fast is spending rising? And it turns out that the causes of high spending are very different than the causes of rapid spending growth. For example, this is a map of the United States, and the colors on the units on the graph are what we call hospital referral regions, which is just a unit of geography. And the colors represent whether the area was high level spending, above or below the median, and high rate of growth above or below the median. So for example, the bright red areas, they had high spending but low, they had low spending but low growth. And the dark blue areas had high spending and high growth. But if you look at, for example, the light blue areas, you'll see high spending but slow growth. And the more salmon-y colored areas, you'll see low spending but rapid growth. And if you do a correlation between the level of spending and the rate of growth, you'll find that they're uncorrelated, suggesting the causes of high spending at a point in time are very different than the causes of healthcare spending growth. So I want to focus a lot on spending growth, so let's talk a little bit about what in general is considered the causes of healthcare spending growth. In general, after a lot of research, I'll present some more evidence in a minute. Long-run drivers of healthcare spending growth is essentially new medical technology. And I'm going to define technology broadly, new knowledge and a whole series of other associated things. So it's not simply advanced imaging services, it's also learning that we need to treat patients with diabetes to a tighter level of glucose control, or learning to prescribe antibiotics for dyspepsia, things of that nature, where we might be using an old service but using it in a new way. And that knowledge of how to use the service in a new way, I also lump into technology. Again, from a whole range of research, there's a series of less important factors. Prices, in other words, holding the exact good constant and just having the price rise is important but less important. Aging, and aging will become more important in the future, but historically, the main driver of healthcare spending growth was not simply that we're getting older. Rising income. So it is true that as we get richer, we spend more on healthcare, but in general, at least in the United States, it's not the increase in wealth that has driven up spending growth. And of course, more generous coverage. As people get better insurance, they use more healthcare, and that drives up spending. All of those things matter. They're just not as important as new medical technology. And let me go through a little bit of the evidence behind that. There's been a range of literature review. I did one in the late 90s. There was another one that came out early 2000s that looked at the role of technology. They use different approaches. A lot of the literature uses different approaches. One approach is the residual approach, which is they look at healthcare spending growth and they try and take out all of the factors I mentioned before: income, prices, things of that nature, and whatever's left, they just label technology. There's another approach called the affirmative approach, which looks in particular clinical areas and asks, why are we spending more? And they can identify some of the specific technologies that have driven healthcare spending up. Surveys of economists commonly view technology as the main driver, and more recent estimates suggest that technology and technological progress accounts for 25 to 50% of spending growth. Why the range? Well, there's a nuance in thinking about this, which is a lot of technology development is driven by the generosity of coverage. If you treat that technology as just technology, then the whole category of medical technology accounts for 50% of spending growth. But if you treat the insurance-induced technological development as caused by insurance, then you put more of the spending growth into the insurance category, less into the technology category, and you end up down around 25%. The key point, though, is really think about the way in which we treat different diseases, and you will realize that we treat them very differently than we have in the past. The types of technology changes over time. So in the 1950s and 60s, and again this is here in the US, the real technologies that were new and were driving up healthcare spending were laboratory tests and x-rays. We don't even think of those things often as technologically sophisticated now in many situations, but in the 50s and 60s, that's what was driving spending growth, a dramatic increase in the use of those services. In the 70s, there were bigger ticker items, Vbid, which is open heart surgery, C-sections for childbirth, radiation and chemotherapy for breast cancers. In the early and mid-90s, we spent a lot of time talking about pharmaceuticals. More recently, we've talked about advanced imaging and biologics. The broadest point is, it's part of the human condition that we fall ill, and we strive to find ways to address that illness. The exact nature of what we're doing changes over time, but we do treat conditions very differently. It's very different to give birth now, to have cancer now, to have heart disease now, across almost any clinical condition you can think of. If you have orthopedic problems, there's a new drug, a new procedure, some new technology related to maybe it's a surgery, maybe it's some other type of treatment, but one way or another, there seems to be new services, and the use of those services, as valuable as they may be, I'm not saying that there's anything wrong with those services, but it's the use of those services which over long periods of time drives up spending growth. Simply put, what we're spending for now in 2015 is very different than the type of health care that we were buying in 1990 or 1980. And that's because, thankfully, there's been rapid advance in medical technology. And I might add, there's evidence that on average, that technological advance has improved well-being. Although, as I mentioned at the beginning, it does create financial challenges. So what we'd like to be able to do is we'd like to be able to keep the good parts of technological progress and get rid of the parts that might be wasteful. The problem is, it turns out it's very difficult to identify waste. So I want to talk in general about how, at least here, I think about waste. This is from an article by Don Berwick and Andrew Hackbarth looking at waste in the U.S., and they identified a series of different types of waste. There's failures of care delivery. You simply do the service wrong. You misdiagnose somebody, some type of waste like that, and they estimate quite a lot of waste in the grand scheme of things here in the U.S. Another type of waste is failure of care coordination. You discharge someone from the hospital, but you don't coordinate. You don't coordinate with the post-acute care in one way or another, and the person becomes ill and has to come back to the hospital. That's another type of waste. Then there is over-treatment. We simply deliver services to individuals that they really don't need. Notice that the over-treatment is the largest, at least in the U.S. Medicare data that they estimate. here in the U.S. there's a lot of administrative complexity that they think adds waste, and what we call, again, in the U.S. pricing failures is a euphemism for simply the prices charged by the providers are much higher than they need to be. And for those of you that have spent time in the American healthcare system, you realize we have very high prices here. In any case, there's a lot of broad measures of waste that people look at. The problem is that in order to really get at that waste, you have to identify it. I want to focus now on the overtreatment row when people are getting services that they haven't perhaps needed. And the challenge with that historically is the medical community has been hesitant to identify and label certain types of services as wasteful. But recently in the United States, there's been a number of initiatives to identify waste. There's an initiative by the American Board of Internal Medicine to identify wasteful services. That's called Choosing Wisely, and they've asked over 70 specialty societies to identify commonly used but not useful healthcare services, and those societies came up with over 400. There's also something here in the United States called the U.S. Preventive Services Task Force, which is an independent volunteer panel of national experts looking at prevention and evidence-based medicine, and they have labeled services with the level of evidence that supports them, A, B, C, or D, or a D grade suggests that actually the service might be harmful. I'm going to talk about some of those services in a minute. One of the problems is once they're listed, there's a question about how you actually identify them using claims data. So I'm not sure about everybody on the line, and if you have access to broad claims data here in the United States, we use health claims data. And there's a company called Milliman, and Milliman has a group within it called MedInsight, and they have built something actually in collaboration with a colleague of mine and myself called the Health Waste Calculator. But to give you some idea of these Choosing Wisely recommendations, here's just two of them from the American College of Cardiology. I'm not a physician, so when it comes time for questioning, please don't ask me to defend these clinically. I'm just repeating them. I'm the messenger. Don't perform stress cardiac imaging or advanced non-invasive imaging in the initial evaluation of patients without cardiac symptoms unless high-risk markers are present. Don't perform annual stress cardiac imaging or advanced non-invasive imaging as part of routine follow-up in asymptomatic patients. Here's the set, just again, two from the American College of Emergency Physicians. Avoid CT scans of the head in emergency department patients with minor head injury who are at low risk based on validated decision rules. Avoid CT, CAT scanning of the head in asymptomatic adult patients in an emergency department with syncope, insignificant trauma, and normal neurological evaluation. One thing that's interesting about this one, notice that the emergency physicians' recommendations were about not doing imaging procedures. And this was true. Many of the specialties picked services used by other specialties in their identification of waste. Here's the radiology one. Don't do imaging for uncomplicated headache, and don't image for suspected pulmonary embolism without moderate high pretest probability of a pulmonary embolism. If you note, one of the problems there is that it's hard to tell how do you identify what moderate or high pretest probability is, and how do you know if a lot of those services are being delivered? And this is where the health waste calculator comes in. So to give you a very quick smattering of the health waste calculator, what Milliman has done is they've taken a number of waste categories, and I just have 30 here, but you can see some of the ones. For example, if you look at 14 and 15, you'll see those are related to CAT scans. Colonoscopy 13, just to be clear, colonoscopy is a high-value service in many settings. This one will be in a very specific type of patient based on age ranges, for example, giving a colonoscopy for somebody who's very old, for example. So there's the issue here is, if you recall from the Choosing Wisely recommendations, a service is not wasteful or not. It really depends which patient gets the service. So all of the recommendations talk about the nature of the patient population to whom the service is being delivered. And what the health waste calculator does is it provides, using claims data, an ability to identify and quantify the amount of waste, so people in a delivery system organization can identify different healthcare providers by their amount of waste and perhaps address ways to reduce that waste. So far, Milliman has coded 30 measures, and they're hoping to get to over 400. They've used it in practice. I haven't been involved in this, but they used it, for example, in the state of Virginia. Now, Virginia has something called an all-payer claims database, or if you see at the top of the slide, an APCD. And what that allows them to do in the entire state of Virginia is look to see where the waste is in the system, and then they quantified that. So, for example, there was almost $40 million that they were spending in Virginia on annual EKGs or cardiac screenings in people for whom they thought that was wasteful. Routine pap smears were considered wasteful. NSAIDs for hypertension, heart failures were considered wasteful. Antibiotics were considered wasteful, and PSA testing for wasteful. All told, they identified in this particular case up to 20% of spending that was waste. I think that's high. We've done some analysis that suggests if you look at different measures of waste, you'd probably end up close to more like 5%. And part of the problem is not all the things identified are necessarily wasteful in a specific case, but it does give a sense of where people working in the system might be able to try to identify value. So the goal here, of course, is not to prevent any EKGs or PAP screens or NSAIDs or antibiotics or PSAs. It's just in the specific populations that are identified by the various recommendations, and at least the folks in Virginia felt this information is useful for going back into the system to begin to try to identify ways to reduce that waste. What I want to talk about now is some solutions, how one goes about reducing waste, controlling spending. And as an economist, it might not be surprising to you that most of the rest of my talk is going to relate to incentives. So I'm going to divide the incentives up into two categories. The first one will be payment. The second one will be consumer strategies. Payment is essentially the way that we pay the healthcare sector. The incentives for physicians and hospitals and everybody else on the supply side of the system. How are they paid? What are their incentives? The second thing that I will talk about will be, I broadly call consumer strategies, ways in which we engage consumers in controlling healthcare spending. I'm going to focus on the first one, benefit design, the financial incentives that consumers face. But there's a series of others that I'm not going to talk about today on the phone very much, disease management programs, wellness programs, that are worth some discussion, but I won't emphasize here today. So essentially I'm going to start with the incentives for physicians, and I'm going to move to the incentives for patients. So starting with the physician incentives. You know, this is a difficult webinar to give because I have a feeling I'm talking to people spread all across the globe, and that they are in healthcare systems that use a whole wide range of providers. Here in the United States, we focus on a fee-for-service system where providers get paid for service they provide, and the services are very, very narrowly defined. There's, you know, over 20 different types of CT scans, for example. There's 10 different offices. It's based on the level of severity and whether it's a new or established patient. There's a vast array of services that are defined, and of course, even for a given service, there's different fees based on whether you're the physician or the facility, and it gets broken up in very complicated ways. This fee-for-service system incentivizes providers to provide a lot of services, which is why, of course, we think in the United States this incentive for quantity over quality has led to the type of waste that I was talking about before. It's very hard in these systems to get the prices right. I used to be the vice chair of something called MedPAC, which here in the United States is the independent government agency that advises Congress on the payment rates for Medicare. And I can tell you after a few years of doing that, it's very, very hard to get the fee-for-service prices right. Another problem with fee-for-service is payment gets fragmented, so there's very little incentives for the hospitals to coordinate with the post-acute, even between the hospitals and the physicians. The fee-for-service system, because the services are so narrowly defined, does provide incentives for fragmentation and not for coordination. We've started here in the United States with a fee for coordination. In other words, we've defined a whole new healthcare service, which is not actually healthcare, it's just coordinating healthcare, and we will see over time how that works. It's also hard in a fee-for-service system to impose accountability. Who's responsible for the patient's outcomes and the amount that's spent on them? In a fee-for-service system, everyone is very reactive. They just are responsible for delivering the one particular service they're getting paid for. In this type of fee-for-service system, the way that we would control spending would be by lowering fees. And in general, there's not a lot of enthusiasm about just lowering fees, because you don't solve some of these other problems about fragmented care, incentives for quantity, lack of accountability. So in the United States, there's been a huge move in the past 5 or 10 years towards payment reform. The goal here is to move away from fee-for-service. I'm going to talk about 3 different types of things. I'll emphasize the last one, but I'll briefly touch on each of these. So one of them is provider budgets, and this happens a lot across the globe. It's much less common in the United States, although it is being done in some places. I'll talk in a minute. A provider budget would be you give a hospital a budget, or you pay a physician's salary. You simply look at the different types of organizations and people who are delivering care, and you pay them a fixed amount of money, and how much they get paid doesn't really depend on how much they do. There's episode bundling, where you look at certain episodes of care, say a hip or a knee replacement, and you pay for that entire episode of care. Or there's patient bundles, where you essentially have a fixed budget per person, and some organization is responsible for that person's clinical and economic outcomes based on their global payment. It used to be called capitation. It could still be called capitation. We try and shy away from the term capitation here, but essentially it's a fixed payment per person, and that organization or physician that accepts that payment is responsible for the entire amount of spending and the resulting quality. All of these things have a few basic features. They transfer risk to providers. So now if there's a lot of spending, the providers bear some of the risk. They include a pay-for-performance component to make sure the quality doesn't suffer. And crucially, at least here in the United States, there's a big emphasis on data support. So let me run through these quickly. I'm going to start with provider budgets. So an example would be to give hospitals a fixed budget and maybe pay or pay workers a salary. There's several issues with this type of approach. One is motivating efficiency and quality. If the providers that took the budget don't do a good job, there's not a lot of incentive for efficiency. There's not a lot of incentive to provide good quality. It's really not a very patient or consumer-centric system. It's very hard often in these systems to adjust to changing demand as the population shifts. So you have a hospital in a particular area, it gets a particular budget. If the population grows in that area or shrinks in that area, some changes to the budget must be made. That's often hard to do. Sometimes that's not an analytic problem. Oftentimes it becomes a political problem. It's also hard to adjust for market share changes. So, for example, here in the United States, and I mentioned this below, a system like this is going into place in Maryland. In a situation where there's just one hospital in an area, you can pretty much manage the budget of the hospital because they're treating all of the patients. But when there's multiple hospitals in the same area, it's hard to get the budgets right, because if the market shares shift between hospitals, it's hard to know what should happen. You don't want the hospital to save money for itself by shifting its patients to some other hospital, and it's hard to make those technical adjustments. It's also hard to adjust for sites of care, particularly as technology changes. So as more and more things become outpatient, or as there's new type of providers like ambulatory surgery centers and things like that, the budgets and everything have to change, and sometimes that's a challenge in these types of models. essentially the budget process becomes complex, it becomes political, there's some analytic challenges. Nevertheless, you see the beginnings of this here in the state of Maryland, and frankly, across the globe, I think there's elements of this in many national healthcare systems. In the United States, there's more enthusiasm now for something called episode bundles. So I'll talk about episode bundles a bit. An example would be that you bundle the services across providers and across time for an entire episode of care. So an example would be childbirth or hip or knee replacements. For example, in childbirth, you might have a fixed payment for the facility and all the physicians for all the prenatal visits and for some postnatal care, maybe starting 9 months before the birth and going 3 months after the birth, and that would be one fixed fee regardless of what is spent in that episode of care. Medicare now, Medicare does not have Medicare is the system largely for covering the elderly in the United States, so they don't have a childbirth bundle, it turns out, but they do have, they are working on bundles for hip and knee replacements and a series of other services. The state of Arkansas, largely driven by their Medicaid program, which covers low-income Americans, has a system of bundled payment, which I'm going to talk about in a minute, at least conceptually how that system works. And of course, in the Medicaid population, childbirth is a really big deal, and they in fact do have a childbirth bundle. The way that the system works in Arkansas, and actually many systems, is it starts out using the exact same fee-for-service system that we have right now. A patient will seek care, the providers will submit claims, and the payers will get reimbursed using the fee-for-service system. Then what happens is, analytically, all the claims are rolled up into a 12-month performance period, and the payers review the claims and assign them to a principal accountable provider. So if it's a childbirth, it's the provider that's delivering the baby. If it's a hip or knee replacement, it's typically the surgeon. They calculate the cost per episode for and the quality outcomes for all of a provider's episodes, and they compare that. They compare all the providers to one another on their average cost per episode. If the provider is low, they share some of the savings, and if they're high, they have to pay some money back to the state. So an example here in Arkansas, and this is just conceptual, although they've done this, is they would take all of the providers and they would graph their average costs. The ones in red have high costs, the ones in green have lower costs, and if you were a provider and your average cost for, say, childbirth or surgery, depending what type of physician you were, was above the threshold, you would have to pay some of it back to the state. You'd have to write a check to the government. And if your spending was lower than necessary, say you're in the green, you were actually given some money back. You got extra payment beyond the beyond what your fee-for-service money would have suggested you get. And so this gives incentives for organizations that are below to reduce their spending. So for example, we're doing analysis now, but at least in the area of childbirth, there's an incentive to reduce the use of C-sections because lower C-sections rates will move you to the right on a graph like this, and you'll be able to share some of the savings. In a fee-for-service system, there's a large incentive to do C-sections. There's a belief that there's too many C-sections done in the United States, and a system like this can change those incentives. I might add there's a quality component layered on top of this, so outcomes matter as well in how people get paid, and often you don't get to keep any of the savings if your quality measures don't look good. There's a lot of issues with this type of episode payment, how you set and update the rates. It's hard to get the contracts to work over time. You need to have coordination between, say, the hospital and the physicians, and in some cases, like the case of hip or knee replacement, the post-acute services, and it's hard for those organizations necessarily to coordinate. There's a question about who keeps the savings. Oftentimes, it's the principal accountable provider, which means if they saved money by keeping money out of the hospital lost the money, and the principal accountable provider kept it. Sometimes that creates some issues. There's concerns of risk, particularly risk adjustment. If you're spending a lot of money because your patients are sicker. All these systems try to have risk adjustment embedded, but it's hard to do. My biggest concerns relate to chronic care. It's very hard for episodes to work when people have chronic care concerns because often people have multiple chronic conditions, congestive heart failure, diabetes. It's hard to make those things work and to figure out if someone goes to the doctor for one or two things, which physician should be accountable. It's easier to think about the principal accountable provider for a childbirth or a surgery than it is for diabetes care, congestive heart failure, or when somebody has multiple conditions going on. And so as a result, these types of episode payment models have really been focused on specific conditions that have a very clear start triggering event, like a childbirth or a surgery. There's more enthusiasm in the United States for population-based payment. So what we see here is a fixed amount of money per person. And the way they work, there's always different variations, but essentially they create a fixed budget for each patient. It's risk adjusted. It gets aggregated to the population level over time. And then what you do is you compare the spending for that population. Again, fee-for-service continues underneath this, so you look at the fee-for-service spending, you add it all up, you look at the spending at the population level, you compare it to the budget. If the spending is above the budget, the organization that has responsibility for the person has to share the losses, and if the spending is lower, they get to share some of the gains. So we looked, for example, at something in the United States here in Massachusetts called the Alternative Quality Contract, which is an example of one of these types of global budgeting models, and over time, it saved up to 10%. There were different cohorts that joined. Each cohort, one joined in 2009, 10, and it's the physicians that were joining. They started out saving, 2-3%, but after 4 years, they were saving about over 10%, 13, 14%. Half of that was because they were shopping for lower price providers. Half of that was because of more efficient utilization of care. Most of the savings were in the sickest patients, so we broke the patients out into risk quartiles. Of course, most of the money, healthcare spending is very skewed. Most of the money is spent in the fourth quartile, and that's where most of the savings were. Obviously, people are very worried about quality. Well, before I talk about quality, there was another, in the AQC that I was just discussing, the measures of quality suggest they actually got better. The Medicare program opted their own version of this that are called accountable care organizations. The evidence suggests that they saved about 1.2% in their first year. Again, this is the very beginning, and there's no price variation. Most of that came from, percentage-wise, from more efficient use of post-acute care and a shift from the hospital outpatient department, which is very expensive, to office-based care. For a total savings in year one of about 1.2%. People were concerned about quality. There were really no differences in many of the quality measures, chronic care services, CHF, COPD, diabetes. And for some of the preventive services, in fact, it looked like the quality got better. More people were getting eye exams. More people were getting tested for diabetes, for example. Patient satisfaction actually rose, particularly for the more complicated patients. What these organizations were doing is they were finding sick patients, they were going out, they were figuring out what services they needed, and they were trying to provide those services. In other work that I'm not reporting here, we looked at a measure of waste similar to the health waste calculator, and we found that they reduced the use of waste by about 4.2% in these programs. There's a number of issues with these models. The most important one might be how you attribute patients to systems. Here in the U.S., there's a number of ways that we do that. Again, like with the episode payment, how you set and how you update the payment rates. Getting the organizations, the hospitals, the post-acute settings to contract together and make sure they can share savings is sometimes complicated. And again, like episode payment, it becomes complicated about who shares the savings. Here in the United States, the hospitals are very worried because these models give savings to the primary care physicians, which gives the primary care physicians an incentive to keep people out of the hospital, which is a financial challenge for the hospitals. And again, what people worry about here is the ability of these organizations to manage the risk associated with these new payment models. Deep breath. So that's my summary very, very quickly of incentives for physicians and hospitals and the supply side in general. I'm going to spend a little bit of time talking about now incentives to patients. Many systems around the world don't charge patients anything. As an economist who believes in markets, we do think there's, at least I think there's some role for benefit design. I will be relatively brief in how I think about and how much I talk about different aspects of benefit design. But let me outline a whole number of strategies that are used. One, of course, is just to charge people more for their premiums, make people pay more for coverage. In the U.S., that portion is often called a co-premium. In some models, that's called premium support. You give people a fixed amount of money, let them go out and buy coverage. And of course, with the fixed amount of money, their incentive is to buy less expensive coverage. There's another approach, which is instead of charging people when they buy their coverage, charge them when they get their care. And the traditional approaches include using co-pays, which is a fixed payment when you go to the doctor or buy a service, co-insurance, which is a percentage of the fee, or deductible, which would mean the patient has to pay the entire bill up to a certain amount, and then they get coverage after that. You see that in some of the reforms of the Medicare supplemental market, trying to manage the amount that patients have to pay out of pocket. Those tend to be not very targeted approaches. The remaining three I want to discuss are more targeted approaches of engaging beneficiaries. The first one I'll just mention, I'm not going to talk about it much, as reference pricing. In the United States, there's wide variation in prices across providers. The way reference pricing works is you pick a fixed amount you would pay for a service, say a colonoscopy. If the person goes to a place that costs more than that, they have to pay the difference. It gives an incentive for patients to shop for the lower price providers. Tiered networking is very similar, except instead of it being service specific, it has to do with an entire system. So for example, here in Boston, we have some very large healthcare systems. In a tiered networking model, the patients that go to the more expensive systems, often quality is also included in the tiering process, though. The patients that go to the less preferred, that is expensive or low quality systems, they have to pay more. Both reference pricing and tiered networking focus on where people get their care. I'm going to focus less now on where they get their care, because I think in many places that's not really an issue, and instead I want to focus on the idea of value-based insurance design, which focuses on what care people get. Recall from the very beginning, there's a lot of waste in the system. Some services are very high value. We define them as quality. I mentioned them when I spoke about quality and payment models, things like eye exams for patients with diabetes, a whole series of high-quality services. And then there's low-value services like the Choosing Wisely services. The idea behind value-based insurance design is you make sure that patients don't pay anything for the high-value services, but you charge them more for the low-value services. So that raises the question about exactly what do we mean by value. In fact, it's probably a mistake of mine. I've been talking now for about 35 minutes about how to create value in the healthcare system, and I never defined value. So I guess you live and learn. Anyway, I do get to it eventually. The idea is that I basically equate value with a cost-effectiveness ratio. So if something is cost savings and doesn't harm you, that would be high value, but also things that are cost effective, that cost less than, say, $100,000 per quality adjusted life year, that also would be high value. In fact, I think the threshold should be higher than $100,000. I think it should be about $250,000 based on research that we've done. But in any case, something that's cost effective would be considered high value. There's places like in the UK, the National Institute for Clinical Excellence, NICE, which would use sort of a different threshold for measuring value. And then things that are low value would be things that are not cost effective, things that rise above that threshold. So the Choosing Wisely things, those would be in that latter category of not offering value. So in these insurance design strategies, there's different versions. One of them is you simply target a service, something like blood pressure medication. The problem is, as I mentioned earlier, the service itself is not high or low value. It depends on who gets it. So you could look at a patient group and target high-value services only for those patients, say blood pressure medications for patients with diabetes. In the United States, at Michigan, they had a program called Focus on Diabetes, which had a whole range of clinical quality measures, things that diabetic patients should use, and defined those and made sure that there were no cost there was no cost sharing for those services for patients with diabetes. They aligned their disease management program with the financial incentives. Another variation in Vbid is whether you only lower copays for high-value services or whether you actually increase copays for low-value services. And that degree of targeting matters, but again, different systems are more willing to engage the patient. In the UK, for example, my understanding is they really don't engage the patient much. We did some evidence, and again, as an economist, it's nice to be able to say that when you lower copays, utilization goes up. Not necessarily by a ton, but by a fair amount. This was a study where they looked at high-value medication classes, and they lowered the copays and found that people used the medication more. Non-adherence was a big issue, and by lowering the copays, they reduced cost-based non-adherence. A lot of people think that you can pay for this lower copays because people have fewer adverse events. I wish that were true. It turns out not to be the case. It is true that people have fewer adverse events, but they don't fully offset the added payer spending. That's really just related to how sick the population is and the number of people needed to treat in order to reduce an adverse event. In order to justify this financially, you have to look, for example, at productivity gains. If people are working more productively. That's harder to justify in, say, a Medicare or older population. Another way to finance this, of course, would be to increase the amount that you charged for low-value services, say some of the Choosing Wisely services. This is a challenging type of strategy to use. It's hard to identify the high and low-value services. My advice is don't try and get it perfect. Just start with those we know. As I mentioned, Choosing Wisely and the health waste calculator, they've identified some services we think might be low value. Almost every quality system has some set of services they consider to be high value. Start with those. Getting the information technology right is often a challenge. There's a growing number of private vendors to help you. That's not only for things like value-based insurance design, but also some of the reference pricing or tiered networking issues allow people to shop. There's really been an amazing explosion of the availability of information technology to help people choose the services that they purchase and from which provider they purchase those healthcare services. There's a lot of concerns about communication, how we educate people to be more sophisticated shoppers, and how we build new tools to enable them to shop. There's a lot of concern. Many of you on the phone and the webinar may share these concerns about using benefit design as opposed to supply-side strategies. One of them is if you charge patients, they reduce the use of services they reduce the use of appropriate services in about the same proportion as they reduce the use of inappropriate services. So you see if you charge people more, they reduce use of valuable preventive services or valuable pharmaceuticals. Again, value-based insurance design can mitigate some of that problem by not charging people for the high-value services, but value-based insurance design is never going to be perfect. There's a concern about how much risk we transfer. As a general rule, insurance is meant to mitigate risk, financial risk for individuals when they have healthcare issues. If you use a benefit design strategy, we're transferring risk onto individuals, and in fact, a lot of that risk is borne more heavily by lower income people, and so we worry a lot about how a cost sharing or benefit design strategy would influence health disparities. So my summary, I think I'm roughly on time, is that healthcare spending growth over time is driven by new technology. We have to direct our energy not to stopping technological progress, but instead to using technology wisely, to identifying and then eliminating waste. And there's growing tools like the health waste calculator to enable people to do that, but we're really just at the beginning of the journey. There's new payment models which are promising but imperfect. The appropriate strategy, whether it's a provider type budget or a episode payment model or a patient type budget, will depend on the environment. And I wish I could say what would work in one place would work in another place, but in fact there's a lot of variation culturally, politically, in terms of the infrastructure, so there's no one magic solution. Cost sharing strategy or consumer oriented benefit design strategies also can work, but there's concerns. They transfer a lot of risk They exacerbate disparities. You can solve some of that through sophisticated cost sharing with value-based insurance design, but we're really at the very beginning of developing a value-based insurance design program and figuring out how to get people to understand it and to respond appropriately becomes a challenge. Certainly you don't expect somebody having a heart attack to really be able to think through and be a perfect shopper for exactly what type of services they should use. So there's going to be limits as to how much you can use these consumer-oriented strategies. So in the end, I think, fortunately, we're going to have continued innovation in healthcare spending and our spending growth, and actually I should say, fortunately we're going to have an increase in medical innovation, and our challenge is to figure out how to manage that innovation efficiently so we can manage the associated financial burdens. It's going to require some combination of supply-side incentives and patient-level incentives, and I think we're just beginning to figure out which ways might work in which different settings. So that brings me to the end. I think we have room for about 15 or so minutes of questions, so I'll stop there.
Well, thank you very much, Professor Michael Chernew, for a very interesting presentation. And folks, we are now open for the question and answers. If you have any questions, you could put it in the chat box, question box, or you could raise your hand. There is a hand icon available on your webinar console. So if you click on it, we can have an audio established connection with the professor. So let me go to the question box. There's a question. Healthcare spending growth has slowed down recently. Do you think that will continue?
Yeah, so it is true that there's been a period of slow spending growth. We've had slow spending growth in the past, and so there's a question about whether the problem will just resolve itself naturally. I'm not so optimistic. I don't think we'll return to very, very rapid spending growth that, say, we experienced in the United States, but I do think healthcare spending growth will rebound. Here in the United States, we've seen some evidence of a rebound in healthcare spending growth, largely driven by new pharmaceuticals, but by other services as well. Some new types of procedures and greater spending on hospital services have driven spending growth up again in the United States. So I think that the bottom line is that as long as humans get sick, there will be a need for new medical technology and new services, and as long as there's a need for that level of innovation, there will be a need to figure out how to manage it. I guess, although I appreciate the question about whether I think the healthcare slowdown will continue, spending growth slowdown will continue, I think a better way to think about it is whether or not we will allow healthcare spending growth to rebound. It's really about what we do as opposed to something that just generically happens to us.
Thank you very much. We have another question from Brother Metwali Abdul Salam. I'm not sure if I understood the question, but let me read it as it is. The question is this lecture a part of what we call it LLQP, Life License Qualification Program, that includes life insurance and health insurance?
Most of the stuff that we have looked at doesn't include life insurance. It just includes health insurance. And so there is a segmentation in people insuring their life and the finances that they get to support their family should they pass away. But the health insurance portion of this is central. And in fact, almost all of the innovation going on in the United States is on the health insurance side. And it's the health insurers that are changing the way in which they pay providers, and they're changing the incentives that patients face. So I guess in some parts of the world, it's not working through an insurance model, but here in the United States, we really work through a private insurance model, and in fact, also a public insurance model, Medicare and Medicaid. They're government programs, but they function very much like insurance programs where people are given benefits and payment models are put in place. So I hope that was an answer.
Very much. There's another question from Brother Sajid Aziz. Does this value create cost effectiveness in charitable health sector as well?
I think so. I think it is hard to know a single answer to that question. In the United States, the charitable healthcare sector has behaved very much like the non-charitable healthcare sector. And so I do think a focus on value in either sector will increase cost effectiveness, and I consider cost effectiveness and value actually pretty synonymous. The real question in all of these areas is how do you go about doing it? And I think the problem has been that in the United States, people have often thought the charitable healthcare sector would just be more efficient, and it's really not. It's actually quite similar. Other people, of course, particularly economists, think that the private sector would be more efficient, and in some ways it might be, except you see a large amount of waste in the private sector as well. A lot of that is because it's not that people are intentionally trying to be wasteful. I don't think that any provider in the healthcare system wakes up in the morning and says it's a good day to be wasteful. It's just the information has not existed, the structures have not existed to promote cost effectiveness at an individual service delivery level or at a population level. And we're still struggling for how to do that. My personal view, again, as an economist, is you have to start with an incentive system that encourages people to produce cost-effective care, be that in the charitable or the other parts of the system, and then find tools to enable to succeed given that incentive system.
Thank you very much. We have another question from Sister Sayeda Ansari. More or less, it's a personal question from her. My mother is 70 plus. Can you please tell me what aspects do I need to keep in mind while buying health insurance for her?
Well, that's going to depend a lot on where she is, and I'm sorry I can best answer that question for the United States, but and a lot of it would depend on the actual medical conditions she would have. But in the United States, you would have Medicare insurance automatically, and Medicare is not a very good insurance package, so you would have to think about how you might want to supplement that insurance package. There's several ways to do that depending on where, well, across the country. In the United States, there's two ways that people typically buy that insurance if it's not provided by their employer. One would be through a health maintenance organization or some other type of managed care plan, which would help coordinate coverage. I tend to like that a lot, and I would look at the ratings of the specific plans in the right area to make sure that they look like they provide high quality coverage and have good outcomes. In general, there's a number of rating systems to look at the managed care plans. Sometimes you don't like the physicians that are available through the managed care plans, and again, you have to shop to figure that out. And so there's supplemental coverage you could buy from a number of organizations. The largest one in the United States is sponsored by AARP, which is for retired persons. But I won't go into that much more because I'm not sure it's relevant if you're not in the United States. But in any case, if you're in the United States, you can look at AARP Medicare supplemental coverage. There's actually quite a potential gain for shopping for better coverage, and the United States has standardized some of that coverage to facilitate shopping, but it becomes a very local issue. And I think the key issues are to understand, does the quality seem good if you're in a managed care plan? Are your physicians covered if you're in a managed care plan? And if you're not, have you got the level of coverage that you might need given what your budget is? Again, that's a tremendous question because it just illustrates how difficult it is to shop and how hard it is to shop without someone that knows your exact situation. And I think, again, as an economist, I'm a supporter of markets in the healthcare sector, but it does raise very complicated questions about what to do, and many people don't like to face those complicated questions. So for advocates of a system that just provides care for everybody and doesn't make people shop, that's certainly a lot easier, but you worry you're not going to get a good consumer-centric healthcare system if you do that.
Well, thank you very much. Another one, a quick one. We have recently seen some viral videos on usage of drones in the healthcare sector replacing ambulances in the future. How do you see its usage from innovation perspective?
I think we're ways and ways and ways away from seeing drones in the healthcare sector. There's a lot of technology. I'm going to jump away from drones because I simply don't know a lot about them, but certainly telemedicine has become a really big issue, and it's growing very rapidly where patients, particularly in rural areas, can access providers at large medical centers without having to travel there. And for people with chronic conditions, as our medical care system moves towards chronic conditions, there's a range of things that telemedicine can help with. A lot of situations where you can have people's biometric information sent to a provider, but even other things, rashes, for example. Instead of having to travel a long way to have a dermatologist look at a skin rash, you might be able to do that with a specialist over the phone, and other diagnostic work. So I think we are at the beginnings of an era of much more rapid technological advancement in the delivery of care. And incidentally, while I was talking about technology raising healthcare spending, that was often technology around new services. There's a lot of people who believe some of these other technologies like telemedicine will reduce spending. The challenge there is, even if it reduces spending on a specific case-by-case basis, it may dramatically increase the amount of services used. So, for example, someone who might have to travel a long way to have somebody look at a rash might opt not to do it in the old system. With telemedicine, they might do it for even a minor rash, and you may have a lot more visits, which could end up being much more expensive. So it's really about managing the volume when the access becomes a lot easier, and that's going to be the challenge with a lot of these services. And of course, that's one reason. If you think one way to manage volume is through consumer incentives, where benefit design might be useful. Drones would be a new one for me. They say Amazon is going to use drones to deliver medicines and things like that. We will see. That's certainly not here at the United States. And if some of those are really good examples, send me an email. I'd love to learn more about it.
Thank you very much. We have another one. What role does prevention play in slowing down healthcare spending growth?
Yeah, so there's a lot of folks that believe that prevention will control spending, and I'm a big fan of prevention. If you could see me, you should see I have all these wearable services, wearable things that measure my steps and things like that. I think prevention is important. There's very little evidence that prevention can control healthcare spending growth, in part because prevention tends to be an expense in and of itself. Often it's not as effective depending on the type of prevention. Smoking cessation is a very good financial profile. Obesity prevention, not much at all. So most of the studies that I've seen of wellness or disease management, which focus on either primary or secondary prevention, haven't been very successful at reducing healthcare spending, the level of healthcare spending, let alone the rate of growth. So I'm a fan of prevention because I think it's important for people to stay in good health, but I don't see it as a solution to healthcare spending growth.
Okay, we have one last question. Do you see the trend of outsourcing to grow in healthcare sector, such as in R&D or generating reports or comments on the radiologies?
I do. I see outsourcing as an extension of shopping in a range of ways, and so for certain areas, imaging is one, radiology is one, but for a whole series of things, when you can outsource, I see outsourcing as a real potential. It's unclear how much you can outsource some of the really major procedures, but here in the U.S. there has been a move for centers of excellence, people traveling far distances in order to get certain types of procedures. So I do see a lot more dynamism in the healthcare sector related to outsourcing and the delivery of care. Again, it's small right now, so when I say it's going to grow, and I do believe it will grow, I think it will take a while to really be a major portion of the healthcare delivery system. There's certain things that are just going to be hard to outsource. But within those constraints, I do think there will be a tendency for that type of migration.
Well, that really brings us towards the end of the webinar. So thank you very much, Professor Michael Chernew. Any concluding remarks that you would like to give before we dismiss out?
No, thank you very much. Thanks to everybody who attended and hung with us on the line, and I enjoyed it and appreciate all the questions.
Thank you very much once again. I really want to thank you on behalf of the Madinah Institute for Leadership and Entrepreneurship. And folks, let me also take an opportunity to announce our upcoming program in November, starting from 20 to 26 November in Madinah, the Kingdom of Saudi Arabia, on high performance healthcare organization. I have just illustrated the screen on my browser. It's hpho.mile.org. Professor Michael Chernew is going to be here with us, and he will be delivering a lecture during this program. So please stay tuned to hpho.mile.org for this program, and there are a number of other speakers who will be coming to deliver their lectures for this program. So once again, thank you very much, Professor Michael Chernew. I look forward to seeing you in Madinah soon. And thank you all of those who participated in this webinar and for posting the questions. We are recording this, which will be uploaded on Mile Community, so please stay tuned to community.mile.org. Thank you very much. You all have a good day, good afternoon, good evening, wherever you're calling from. Assalamu alaikum wa rahmatullahi wa barakatuh.